Okay, a couple of questions that have been submitted earlier, probably for Maria. There seems to be quite a move to partial mastectomies long term. Is this a good move, or is it better for women to have a full mastectomy?
Yeah, they've done a lot of trials comparing mastectomy with partial mastectomy. I think if you're going to have a partial mastectomy, it has to be a package with radiation treatment, because we know if you just have a partial, then you do have a high risk of recurrence if you don't have radiation treatment. But what we know is the survival of women who have a mastectomy and a partial is the same. So I think you're not losing out, and you're getting to keep your breast.
And one other question on radiation. Why is the use of Mepitel dressings not being offered to all breast cancer radiation patients, even if they have to pay for it themselves? So perhaps you could just tell us a bit about what those dressings are.
Yeah, my understanding is that basically they're a bit like a second skin that goes onto your breast or onto where the mastectomy's been done, and you shower in them, and they just stay on during your treatment, and they do reduce the redness of the skin and the skin reaction. My understanding is if people do pay for them themselves, the nurses would be very happy to apply them, is what I understand around the country when I emailed people around the country a few months ago. Some centres offer it, and some centres offer it for people who are more likely to get a skin reaction depending on what treatment they're having, and I think it's probably more a funding thing as opposed to any other reason.
Okay, we're open to questions from the floor now. We have one over here.
Good afternoon. Thank you very much. I'm sure on behalf of everybody, I'd like to thank everybody who spoke today. It's been absolutely amazing. I think the one thing that has caught all of us is that things are not conclusive on any form of breast cancer yet. There's still an awful long way to go. And diagnosis is not wonderfully simplistic, which is why I want to hijack this. I was originally diagnosed for my first incidence of cancer in the UK, and over there they run a thing called the Parapet unit, which is a one-stop cancer shop. For most of the women here, and for any men who are involved too, I know it does affect some men, one of the hardest jobs is the beginning, and it's the wait. It's finding out what's going to happen, what do I have, and what's the prognosis. So taking it right back to the beginning, when you ring up and say, I found a lump, you are then required to go to the GP. The GP says, yes, I found a lump, and the next day you go to the Parapet unit. It starts at 8:30 in the morning and it finishes at 4:30. And it's a one-stop, sit in the line and I'll call you through. You do the blood test, you do the ultrasound, you do the x-ray, you do the whole shooting match in one place on one day. And at 4:30, somebody calls you in and they give you a diagnosis. And when they give you the diagnosis, a little Parapet nurse just sleeps in the side and she sits on a wee chair and she listens to everything that's said and she makes notes. And then when he's finished, she takes you through and she runs through exactly what the surgeon or whoever's giving the diagnosis has told you, so that you can reprogram and reprocess everything that has actually just happened and what is coming, and then gives you a set of notes on that and some appropriate websites for you to Google. What's the chance of you guys getting together so we can have the same thing? Because you've all got heaps of cool stuff, but for a lot of these people here, I know that they get one part of the diagnosis there and they wait another 3 weeks to go and see somebody else who may or may not have part of the notes, who then gets another little bit. And for here, a lot of this information has been new and it's big, and we'd love it in one space.
Yes, it would be ideal to have a one-stop shop, but to have the imaging, the biopsy, the pathology all back within the same day may not be feasible, because we could do a final aspiration of a lump and the surgeons really need to know, is it ductal carcinoma in situ or is it invasive, because the treatment is different. And you can't get that from a fine needle. And if we did a core biopsy, again, the pathologist won't be able to give you the answer that day. So it does take a little bit longer in our approach, We can speed things up a little bit more, perhaps, but I think that the final outcome is that when we have all the information, then at least you can make better decisions rather than trying to base surgery on a final aspiration, which we've sort of gone away from. And I think the surgeons need to know the receptor status, which you really can't get on a final aspiration on the same day.
No, they do all the tests in one place, not just that.
Yes, I know, but to get all that information all on the same day, I don't think is feasible.
Okay, did I see a hand up here? Yes, I did.
Kia ora. From a Māori woman's perspective, as a survivor of breast cancer, I'd like to know the mortality rate. I don't want 3 years beforehand. I want to know now, as well as the Pacific Island woman altogether. So I'd like to know the total amount, the mortality rate, as we stand today.
We do have data from the breast screen study, and I don't have the exact figures in my head. The current participation rate of Pacific women, the mortality reduction is about 40%, which is really good. For Maori women, it is less. It's 26% or somewhere around there. But that's partly because they have a lower participation rate. And if we can get the participation rate up to the 70% target, then Maori women should have the same mortality reduction benefits as the rest of the women.
Okay, over here.
Hi, I'm just wondering if you can explain to me. I've had a mastectomy on one side with a transplant reconstruction. Now, when I go and get my mammograms done each year, they will mammogram one side, but they won't do anything on the other side. When I go into a surgeon, he likes to have an ultrasound done on the reconstructed breast because there's a risk that it could come back in the breast tissue that's left behind. Can you explain why that's not done normally?
We don't routinely image the reconstructed side or the side with the skin-sparing mastectomy because we're not going to pick up the cancer any earlier than clinical examination.
Okay, suddenly hands are shooting up all over the show. Just get me moving around the room.
Yeah, just further on that, I've had a double mastectomy and obviously you can't have mammograms now, and you mentioned in your pictures other areas around there that you can get the cancer. How do you check for that in the future?
Clinical examination.
You mean just touch?
You will be able to feel the cancers earlier than we can pick it up. We're not going to get any of the chest wall on a mammogram, and by the time you feel it, then we can ultrasound it.
Won't it be too big when you start feeling it?
No. If clinical examination can find recurrences in the chest wall, only a few millimetres. It's smaller than what we can detect.
Could you have regular ultrasounds
of the chest wall?
Yes.
Again, you're going to be able to feel them before we can see them.
Okay.
And if you can feel it and we can see it, then we can do a biopsy of it.
Okay, thank you.
Okay, perhaps do we have any questions around nutrition? Yes?
Hi, Kaytee. Iodine, if you're allergic to it, what is a good replacement?
Oh, good call. How are you with natural sources?
I'm just allergic to anything that swims in water. Seafood. Iodine on my skin.
Then we'd have to do it. Oh, that's a really tough one.
Okay.
It's a really tough one. You'd want to support it by other means, so other minerals, particularly magnesium, selenium. Is it what kind of cancer?
Breast.
Well, what kind?
R32.
Okay, so you'd be doing things like, I'd go selenium at least 200 micrograms, 400 milligrams of magnesium every day. You want to support the endocrine tissue, right? So normally it would be iodine's your number one. So if you look at the periodic table, you've got your halides, which is your chlorine, fluoride, bromide. Those things you want to make sure you do not have. So I'd be looking at reducing filter your water, get a a filtration system that has fluoride, takes out the fluoride as well as the chlorine, because those are going to cause more of a problem for you in particular. So I can talk to you a bit more about this because this will probably bore the pants off everybody else. But it's really important. So look at the things that can actually inhibit your iodine uptake naturally. We can look at really, really low doses, like really, really low.
Okay, so a hand up over here.
Thanks. I'm just interested to know your thoughts on frozen fruit and vegetables. Are they better than standard, or...?
It's a good question. It depends where they're from. So if you look on the back of some of the frozen berries are actually from China at the moment, or they're from overseas. You have no idea what soil composition they've been grown in. I'd go for OOB, or anything that's... And hey, they still import. They still import from overseas, but at least you've got more of an understanding that they have to put it on the back of the label where they've imported them from. Sometimes snap frozen can be even better, because how long does something stay on the shelf for? Like, okay, they get picked, they've got to sort them out, then they've got to transport them, then they sit on the supermarket shelf for days, if not a couple of weeks, or they're in a storage facility that's gassed to ensure that they maintain fresh. So sometimes they can be awesome. Just check where they're grown from. But good call. Good question.
Hi. Has there been enough study done on vitamin C in breast cancer and preventing it? We hear a lot about taking this lip.
Yeah. I'm not sure if I'm allowed to. It's bloody controversial. If you want to find out more information, actually, this book. There's more evidence on actually giving vitamin C during treatment than there is to not. But I'm sure this is a massive. We'd have a whole conference on this. Most of the research that I've read, actually, personally, this is my personal opinion, no one else's. The research that I've read on vitamin C, even infusions during chemotherapy, which is what a lot of my patients actually still do, quietly, really good results. But the mortality rates aren't lower. It's more, it sails them through chemotherapy with better results long term, possibly. But yeah, please do it.
I'm not a chemotherapy expert, but from the radiation point of view, the way the radiation works, and it sounds a bit counterintuitive, is you need antioxidants to help kill the cancer cells. So we prefer people not to be on high-dose vitamin C while they're having radiation, because potentially it may not make it work as well. Happy for the people to do whatever they want before and after, but just not during the treatment.
Yeah.
Thank you.
Hi, Kate. Just want to know what's your opinion on alkaline water?
Oh, cool. Alkaline water is it's acid and alkaline are both ends of the spectrum. Water should be about 7 pH. So alkalinity, I get lots of questions on this. The more alkaline, or basically the less alkaline your system, the more acidic, the more your body has to pull minerals from the peripherals or from wherever to actually try and balance things out. So it's actually, it's more a question on how much mineralization you can get. So that's your bearing foundation. So yeah, it's really important. Yeah, it can be, but for some people they're actually too alkaline. Yeah, I would normally say yes, but I do things like a hydrogen donating. You can get tablets, or you can actually get a filter that puts more hydrogen in the water, which will automatically help your system better. Alkalization, you can Google it, alkalizing diets. But again, for cancer patients, I've got some who need to have protein. They need to have animal proteins, which are, so-called acidic. This is where everybody's different, and it's more important to make sure the individual is fed correctly. But yeah, good question.
We've still got time for a few more questions. There's a lady in the middle there. Always the ones in the middle who need the microphone.
Hi. Now, first of all, I just have a little observation for Trevor. It doesn't necessarily contradict what you're saying, but from a personal point of view, my experience has been different. I've had 2 breast cancer recurrences, one in my chest wall and subsequently in the scar of having my pec muscle removed 2 years ago. Those were both picked up by ultrasound. They were not picked up by physical examination. I've had breast cancer 3 times and none of them have been picked up in a mammogram. So I understand completely that mammogram is the only modality that's actually proven to reduce mortality. However, in my own case, I would have died by now had I waited for the mammograms to show it. So that was just an observation, and you might want to answer me on that one. But yeah.
Can I say
another question as well?
That we do studies and we draw conclusions for the population. So individual patients need to be treated individually.
Yeah, okay.
So if you're concerned about a lump, then by all means get it checked out and do the ultrasound if it doesn't show up in the mammogram.
Right. I have to say I went through the private system. I don't think in the public system I would have been picked up at all. But because the concerns were, it wasn't until I got to the breast physician and the surgeon that because I had very dense breast tissue, that in fact somebody smelt a rat and went, actually there's something here, and they were determined to find it. Sorry, I didn't want to sort of get hung up on a personal case, but I'm just, there seems to be a wide spectrum, and I have to say with friends of mine, when they sort of talk to me about getting themselves checked out, I always emphasise have a physical examination. But it concerns me that people who've had reconstruction do not get ultrasound in the public system, and that they, it's left until, I was in the private system and it wasn't picked up until it was about 15 millimetres in my pec muscle. Sorry, I also had a question from Maria, which was about radiation therapy. Subsequently, I had electron beam radiation therapy, and I don't fully understand how that differs from the photon radiation therapy, which I had in 2003. And I was just wondering and you haven't touched on it, I just wondered if you could give us a sort of flyby, this is what electron beam is versus the other one.
Yep. So in 2003, you had the photons.
I had the proton,
Yep. And did you have a breast at that time?
Sorry?
Did you have a breast at that time?
I had a reconstruction at that stage.
And then when you had the next lot of radiation?
The reconstruction had been removed. My pec muscle had been removed, and then I subsequently had a recurrence in the scar of that operation.
Yeah, so we tend to use electrons sometimes if we're treating people after mastectomy. So when we're treating people with an intact breast or a reconstruction, we tend to use X-rays or photons. With electrons, they don't like curved surfaces, like the shape of the breast. It doesn't treat very well over that if you've got a breast, whereas when you've had a mastectomy, it's a much flatter area and we can use the electrons. But there's no sort of reason why we don't also use X-rays in that situation. So it all depends on the patient's shape and size and all those things as to what we do. But electrons aren't used for people with an intact breast or with a breast reconstruction because the shape of the breast, and what happens is when you've got curved surfaces, the electrons don't penetrate very well.